And joining us here in Washington, Dr. Anthony Fauci, who heads up the Allergy and Infectious Diseases Institutes at the National Institutes of Health. Doctor, thank you so much for coming. Can you say at this point that this situation in Dallas has been contained?
I believe so. Right now, the way you classically prevent an outbreak is you put the person who's the index person under isolation and care. Mr. Duncan is in that situation. And then you do what you just heard here, is that you do what's called contact tracing. People who've come into direct contact with the patient are observed for a period of 21 days. If they develop symptoms, they're put in isolation, and if they have Ebola, they're treated. And when you put that umbrella over the people who have been the contacts, that's how traditionally, over the years in Africa, outbreaks have been controlled.
Well, is it likely that any of these people, I think there were 9 people that had the closest contact, are they likely to come down with Ebola?
Well, it depends on what you mean by likely. Is it conceivable that they will? Absolutely. I would not be surprised if one of the people who came into direct contact with Mr. Duncan when he was ill will get Ebola. You can't say, you can't put a number on it. It's impossible to do that. But there certainly is a risk. So I don't think the American public should be surprised if you hear that one of them actually does come down with Ebola.
Republican Senator Rand Paul, who is also an ophthalmologist, a medical doctor, says that we are underestimating, in his words, the transmissibility of this disease.
I don't think that there's data to tell us that that's a correct statement, with all due respect. We have had experience since 1976 with how Ebola is transmitted. And it is clear that it's transmitted by direct contact with body fluids, blood, diarrhea, vomit, or what have you. And there's no indication that there is another insidious way that it's transmitted that we're missing because of the experience we've had. So we've really got to go with the evidence base. There's always hypothesis and surmising about that, but there's no scientific evidence.
Well, he even goes so far as to say he's worried about us sending 3,000 Army troops over there. He says, can you imagine how easy it is for disease to spread on a ship, that they may come back and they might, spread it among themselves and then to the rest of the country?
I'm sorry, but that's really not a concern. First of all, the troops that are going over there are going to be fundamentally for logistic purposes: command, control, engineering, setting up the hospitals. They're well trained. They will not be in direct risk in the sense of contact with individuals. And even if they are, the protocols are in place to prevent spread from there. So I don't, and the Army does not, have any real concern that those 3,000 to 4,000 troops are going to be in danger.
We have seen already that human error can play a role here. Is human error the main thing to be worried about right now?
Well, human error occurs. We've seen the misstep in Dallas. It's now been corrected. Certainly, no one's perfect, and there will always be some missteps. But what we need to do is to have layers of capability to overcome that. And if you look at what's happening in Dallas right now, things are going well, particularly with the contact tracing.
But they didn't go very well in the beginning.
They did not. And I think anyone that denies that is not being realistic. There was a mistake there in the beginning. Hopefully, this will be lesson learned so that emergency room and clinic docs throughout the country, when they have someone come in and say they have symptoms compatible with Ebola, you ask them, have you been to West Africa? And if they are, then you trigger the protocol.
You said that we've run out of this experimental drug called ZMapp.
Correct.
That was used to treat 2 Americans who had Ebola. Is there going to be more of that, and where are we on vaccine?
Okay, well, there will be more ZMapp. Unfortunately, it is difficult to produce. A lot is being produced right now. It should be ready in a month and a half to 2 months. We're not going to get it tomorrow or next week. A vaccine to prevent Ebola. We have started a vaccine early phase 1 trial in the NIH in Bethesda, Maryland on September the 2nd. 20 volunteers. We should have data as to whether or not it's safe very soon, probably by the end of this calendar year, and then we'll go into a larger trial in West Africa.
Doctor, we're coming on to flu season.
Correct.
People will show up with flu symptoms. I'm sure some of them are going to think they've come down with Ebola.
Right.
What can you say to the American people right now as we approach flu season?
I think people have to be, and it's understandable, the fears. We respect it and we understand it. To really take a look at evidence. If you are in Massachusetts now and you get a cold, there's no chance that you have Ebola because there's no link between an Ebola case. You've got to look at it in a rational way. The rational way is you get a case of Ebola, it's isolated, and you do the contact tracing. I've heard people say, well, should I be afraid of getting on an airplane in San Francisco? It has nothing to do with Ebola. So you've got to really be rational and have the evidence be the major thing that gets you in your decisions and your concern.
And probably not a bad idea to get a flu shot.
And that's exactly right. Not a bad idea to get a flu shot. Good point, Bob.
All right. Thank you so much, Doctor.